All right, welcome back, guys. So we'll be continuing with our ABIM rapid review, and right now we are focusing on cardiology and internal medicine ABIM exam. So let's say you have a woman coming to your office who has history of systemic sclerosis. Now, all of a sudden, she is complaining of worsening headaches, decreased urine output, elevated blood pressure readings at her home. You check her blood pressure is like 190 over 80s. You order some labs which shows worsening proteinuria. Her creat is 4. Her baseline creatinine is around 1. So what's your diagnosis here? This is scleroderma renal crisis, right? It's a devastating complication of systemic sclerosis. So how would you define scleroderma renal crisis? Number one, you should have new onset of accelerated arterial hypertension, or you should have rapidly progressive oliguric kidney failure if the patient has history of systemic sclerosis. And now the question is, how would you treat? The answer would be ACE inhibitors, right? Even in the acute phase, when you have elevated creatinine, ACE inhibitors are the drug of choice. This is to attempt to salvage the renal function. And of course, if you are thinking this patient has scleroderma renal crisis, this patient would require probably ICU admission, especially if they have features of end organ damage, right? Like, for example, encephalopathy, pulmonary edema, some tachyarrhythmias, or hemolytic anemia because of severe elevated blood pressures. Now, in the studies so far, the choice of ACE inhibitor was captopril. That was the most frequently used ACE inhibitor as per the studies in the treatment of scleroderma renal crisis. But as of the guidelines of 2017, there is no specific ACE inhibitor which they recommend. The recommendation is just you should start immediately high dose ACE inhibitors. Now, what do you think is your diagnosis if the patient is coming to you who has history of non-Hodgkin's lymphoma and the patient has history of chest radiation? Now the patient is coming with weight gain, lower extremity edema, elevated JVP, which does not collapse with deep inspiration. Patient has hepatomegaly, ascites, elevated liver enzymes, and IVC is dilated and does not collapse with inspiration as well. So all the features of right ventricular dysfunction. So what's your diagnosis here? So the things to keep in mind is if someone has history of chest radiation and now they are coming with right ventricular dysfunction like ascites, lower extremity edema, Kussmaul sign, right? You have elevated JVP with deep inspiration. This is all constrictive pericarditis. So how would you treat this patient? So the mainstay of treatment, if the patient does not respond to conservative management like giving diuretics and other medication, would be pericardiectomy. And this pericardiectomy should not be delayed in the patients who have failed conservative management because if someone has advanced heart failure and they have constrictive pericarditis, that's associated with very high operative mortality. Now the next one is, let's say you have a patient who has history of non-ischemic cardiomyopathy with EF of 25%, and this patient still has some exertional shortness of breath. The current medications are carvedilol, Entresto, that's sacubitril valsartan, dapagliflozin, and furosemide. What other medication you think you can add as a part of GDMT? So since this patient is on beta blocker, ARNIs, as well as SGLT, what else can you add? You can add some aldosterone receptor antagonists, right? Like, for example, spironolactone. So these are the 4 pillars of therapy which you should keep in mind. So every patient with HFrEF, you should eventually have these patients on ARNIs. ARNIs are preferred than ACE inhibitors or ARBs. A beta blocker, SGLT2 inhibitors, and mineralocorticoid receptor antagonists. These are the 4 pillars of therapy, and of course, this in addition to diuretics for symptom control. So usually the sequence for HFrEF GDMT should be around like this. So first you try ARNIs or ACE or ARBs, and of course ARNIs are preferred, followed by beta blockers, followed by spironolactone, followed by SGLT2 inhibitors. And if, let's say, patient is not able to tolerate ARNIs or ACE because the creatinine is elevated or patient had AKI, then you can actually switch those ARNIs, ACE, or ARBs to hydralazine and nitrate combination. How would you diagnose if a patient is coming after motor vehicle accident and the patient is hypertensive, has elevated JVP and muffled heart sounds, what's your next step in diagnosis? Should be echocardiogram, right? And in the echocardiogram, we are looking for cardiac tamponade. The things we are looking in echocardiogram is actually that anechoic space between the pericardium as well as epicardium, and usually you can measure that space. If it's less than 10 millimeters, the fluid should be around 300 cc's. If between 10 to 20 millimeters, it could be moderate effusion around 500 cc's, and if it's more than 20 millimeters, then it's a large effusion that's around more than 700 cc's. The signs of early cardiac tamponade are chamber collapse. So you will see collapse of right atrium and then eventually collapse of right ventricle during early diastole, and later on you can also see left atrial and left ventricular collapse. Now things can be a little tricky if the patient already has pulmonary hypertension, because that might mask a little bit of collapse of right heart. What's the preferred therapy for pericarditis? And let's say to find out the cause, you actually do a pericardiocentesis that reveals leukocytes around 2000 with 90% lymphocytes. So would you give NSAIDs, or would you give colchicine, or would you give both? So if someone has, let's say, acute idiopathic or viral pericarditis, like in this case, we would give a combination therapy of colchicine plus NSAIDs rather than NSAIDs alone. And why is that? Why do you want to give combination therapy? This is based on studies which have shown if you use combination therapy, that has lesser risks of recurrence than as compared to monotherapy with NSAIDs. So you can use ibuprofen plus colchicine, or you can use aspirin plus colchicine. And if that combination therapy has a poor response, you can try alternative drugs like indomethacin plus colchicine. What's the treatment of choice for acute myocardial infarction or post-MI pericarditis? Aspirin plus colchicine. Should you use prednisone in these patients? Several studies have shown that if you use glucocorticoids like prednisone, especially in acute pericarditis, it has very high risk of recurrence. So it should be restricted for patients who are severely symptomatic, they have recurrent pericarditis, and who are unresponsive to initial all the pharmacotherapy. So steroids are something you want to use as a last resort. Let's say you have a patient who's coming with shortness of breath, you get a CTPA which shows a large central pulmonary embolism. The blood pressures are around 70s of systolic and 50s of diastolic. So 70 over 50, you tried 2 liters of normal saline, but the blood pressures are still on the softer side. What's your next step in management? You would give thrombolytics to the patients, right? So this is based on American Society of Hematology recommendation that if someone has pulmonary embolism and there is a hemodynamic compromise, they should get thrombolytic therapy followed by anticoagulation instead of just anticoagulation. And if you dig more into the literature, they actually define what is hemodynamically unstable PE. So hemodynamic instability means when you have systolic blood pressure less than 90 for more than 15 minutes, or hypotension requiring vasopressors, or you have clear evidence of shock. That's a definition of hemodynamically unstable PE. What's your diagnosis if a patient is coming after 3 to 4 weeks after they had STEMI and stent placement, and now they are complaining of some chest pain, which is worse with inspiration and lying down, some feeling of fever, patient is taking all the medications appropriately, and you check the troponin, that's negative, you check CKMB, that's negative. So what's your diagnosis? So I said 3 to 4 weeks after the MI, right? So this is Dressler syndrome, also called as post-cardiac injury syndrome, PCIS. Now the treatment for this would be what? So patient is already taking, let's say, aspirin and a second antiplatelet, let's say clopidogrel or prasugrel or Brilinta. So what you have to do is increase the aspirin and keep the other antiplatelet along with colchicine. So aspirin plus colchicine, and you have to keep the other antiplatelet. And the dose of aspirin is the high dose aspirin, not the baby aspirin. So here the dose of aspirin for pericarditis is 2 to 4 grams daily. And if the patient is undergoing cardiac surgery, they actually recommend post-operative prophylactic treatment with colchicine rather than expectant management to prevent post cardiac injury syndromes. So let's say someone is undergoing CABG surgery, they start colchicine 1 to 3 days following the surgery, and then they should be continued on colchicine for 30 days. One of the physical exam finding which can help us to differentiate whether it's pericarditis or pleuritis, because both can have scratchy sounds. So if you ask the patient to hold their breath and if you still hear the sound, that's likely pericarditis. And if the sound is only when the patient takes deep breaths, it's pleuritis. What do you think is the most useful assessment on physical exam if you are suspecting coarctation of aorta? Taking blood pressure in all four extremities, right? So the upper extremity blood pressures would be higher as compared to the lower extremities. And usually the difference of blood pressure between upper and lower extremities is around 20 millimeters or more. What would you do if you see coarctation of aorta in girl? What should you do next? You should get a genetic testing to test for what? Turner syndrome. So Turner syndrome is associated with coarctation of aorta as well as bicuspid aortic valve. The other association you have to keep in mind is intracranial aneurysms. So adult patients who have coarctation of aorta, they are at higher risk of intracranial aneurysm, especially if they are old and if they have concomitant hypertension. What's the first thing you want to do when you are suspecting someone with cardiac tamponade? You have elevated JVP, lungs are clear on auscultation, but blood pressure is on the softer side, and you have muffled heart sound. You have options of would you give IV fluids or would you give furosemide, or would you try maybe dobutamine or some inotropic agent. So the answer should be always aggressive fluid resuscitation. Cardiac tamponade is a preload dependent condition, right? So you should get IV fluids on board from very beginning. So give aggressive IV fluids, and meanwhile you have to arrange for urgent TTE, transthoracic echocardiogram, to confirm the diagnosis, and then you have to consider for immediate either therapeutic pericardiocentesis or a pericardial window depending on the situation. How can you classify heart failure by LVEF? So if someone has heart failure and EF is more than 50%, you call that heart failure with preserved ejection fraction. If the EF is between 41 to 49%, you call it heart failure with mildly reduced ejection fraction. If the EF is less than 40%, you call it heart failure with reduced ejection fraction. And let's say if someone had HFrEF or heart failure with reduced ejection fraction before, and now their EF is improved from baseline, then we call it heart failure with improved ejection fraction. What are some of the characteristic EKG finding you'll see in acute pericarditis? So first one is diffuse concave, like a smiley face, ST segment elevation, and along with that you'll see PR segment depression. Now important thing is those ST elevations would not have reciprocal changes like ST depressions in the inferior leads if you have ST elevation in the anterior leads. And usually there are 4 stages of EKG changes, which is classically described in literature. Stage 1 is you'll see ST segment elevation, which is diffuse. This is secondary to epicardial inflammation along with PR segment depression. Stage 2 is you'll have normalization of ST and PR segments. Stage 3 is you'll have widespread T-wave inversion. And stage 4 is EKG normalization, or you might have persistence of T-wave inversion. Let's say a 45-year-old lady is coming to your clinic with diabetes and you calculate her ASCVD score, and her ASCVD score, let's say, is 6%. Would you start this patient on statins? Yes, it's regardless of estimated ASCVD score. This is for primary prevention, right? So any patient aged 40 to 75 years and they have type 2 diabetes mellitus should be started on at least moderate intensity statins, like for example atorvastatin 20 milligrams. So rosuvastatin and atorvastatin, I remember that as AR. AR is actually preferred for patients who require potent statins because of high cardiovascular risk, or if they require more than 35% reduction in LDL. For those who have kidney impairment, atorvastatin or fluvastatin is preferred for them. And those who have, let's say, chronic liver disease and you need statins, pravastatin at a low dose is preferred over other agents. What lab test you want to get before starting patients on statins? Aminotransferases, you want to check baseline AST ALT prior to starting statin therapy. Would you want to monitor AST ALT? No. What other labs you want to get at baseline? TSH, you want to check TSH at baseline, not something to monitor. Would you check CK? That's something which is not routinely recommended to check at baseline. Very important one. Let's say a young female is coming to you with a question that she wants to get some dental work, whether or not she should take some antibiotics or not. On further questioning, the patient mentions that she was born blue. On examination, you find that the blood pressure on the right arm is, let's say, 90/40, and on the left arm is normal, let's say 120/80. And on auscultation, you hear that she has normal S1 sound, but the second heart sound is split. The patient also has some right parasternal heave, and there is a early diastolic decrescendo murmur on the left lower sternal border. On further questioning, she said when they found that she was born blue, she required 2 surgeries, one after the birth and one after a couple months. So would you give this patient antibiotic prophylaxis for dental works? So the answer is yes, this was a tricky one. So this patient does have history of repaired congenital heart disease, but probably she has some residual shunt from the murmur we are hearing now. So the criteria is you give antibiotics for unrepaired cyanotic congenital heart disease or repaired congenital heart disease with residual shunt or valvular regurgitation. The other criteria include patient if they have prosthetic valves, including transcatheter implanted prosthesis, like for example TAVR. So prosthetic valve. The second one is like for example if the patient has previous history of infective endocarditis. Third one is we talked about history of unrepaired cyanotic heart disease or repaired with residual shunt, and then the fourth one is if the patient has history of cardiac transplant with valvular regurgitation due to a structurally abnormal valve. So, in a nutshell, to remember, any prosthetic valve, previous history of infective endocarditis, history of unrepaired cyanotic congenital heart disease or repaired with residual shunt, and then finally, patient who has history of cardiac transplant and now they have some valvular regurgitation because the valve is abnormal. So these patients would need antimicrobial prophylaxis. Now, what would you give this patient? You would prescribe amoxicillin 2 grams orally 1 hour before the procedure. What would you give if the patient has penicillin allergy? A microlite, like for example azithromycin, or you can also give doxycycline. Let's say the patient had VFib cardiac arrest. You shock the patient. Now the patient has return of spontaneous circulation. You send the patient to ICU. What kind of temperature management would you do for this patient? So this concept is revolving around targeted temperature management, TTM. So TTM can refer to two things, either induction of hypothermia or active maintenance of normothermia. Now, recent studies have shown that there is no benefit in patients treated with hypothermia compared to those who we maintain normothermia. And in fact, 2023 American Heart Association guidelines update states that the goal of TTM during, after cardiac arrest should be avoidance of hyperthermia rather than induction of hypothermia. So you should maintain normothermia and avoid hyperthermia. So maintain TTM around 32 degrees centigrade to 37.5 degrees centigrade, at least for 24 hours. And after cardiac arrest, when would you assess the patient for brain death? It's typically after 72 hours. We already talked about this concept, but let's see if you can get this time. Let's say an elderly patient who is coming to you with fatigue, abdominal discomfort, abdominal distension, and weight gain. He has history of CABG and aortic valve replacement, let's say 15 years ago. And on examination, the patient is mildly icteric, the JVP is high, and there is a crescendo-decrescendo murmur in the systolic area, and you also hear a high-pitched early diastolic sound at the apex. So what do you think is going on? Why this patient is having high JVP, ascites? What is going on? Is it malfunction of the aortic valve, or is it cirrhosis, or is it something else? This is actually constrictive pericarditis again. So you see the features of right ventricular dysfunction, and this patient had early diastolic heart sound, which is actually pericardial knock. So fatigue, abdominal distension, weight gain, and the JVP is high, ascites, lower extremity edema. These are all signs of constrictive pericarditis after cabbage surgery. So, can this be cirrhosis? Cirrhosis can cause lower extremity edema and ascites, but it usually does not cause elevated JVP. And if it were aortic valve dysfunction, then you would see more features of left heart failure, including pulmonary edema.